Right. Well, good evening, everyone. Thank you so much for joining us tonight. This is one of my favorite things to do, and tonight we have the pleasure of moderating this event with one of my favorite people to work with, Dr. James Cullison. Dr. Cullison is an overactive bladder specialist for West Georgia Urology and both a urologist and urologic surgeon, as well as one of the only female pelvic medicine and reconstructive surgery certified surgeons in all of West Georgia. Dr. Cullison specializes in male and female urology, BPH, several novel therapies for voiding dysfunction, among a litany of other things. Tonight, Dr. Cullison will be speaking on overactive bladder, urinary retention, and fecal incontinence or stool leakage, as well as a therapy called InterStim that helps treat all of these symptoms. As I mentioned, I work for Medtronic, and that's the company that developed this life-changing therapy over 25 years ago, probably when Dr. Cullison started doing this. While you may not know the name Medtronic itself, you probably do know someone who has a pacemaker or insulin pump, and that's actually what we were originally known for. Before I pass the mic to Dr. Cullison, just a few reminders, kind of what we were talking about beforehand. Everyone is muted upon entry. Everyone's anonymous. If you have a few minutes, feel free to fill out a Q&A with some questions, as well as answering those polls. So without further ado, let's begin this evening with Dr. Cullison.
Good evening, everyone. I appreciate you logging on tonight and listening to this quick webinar. I appreciate Medtronics for setting this up. We've done this once before. It's very informative. You get to enjoy it from the seat of your own home. And we'll try to make this an easy presentation, relax, and you can save a lot of your questions to the end. I'll be glad to answer them. But again, yes, I'm Dr. Cullison. I've been in Carrollton, Georgia, serving out of Villa Rica and Bremen as well since 2004, 19 years. I was in private practice in Ohio prior to this, and I learned to do this procedure from a gentleman at Cleveland Clinic. And I've had a lot of experience with overactive bladder in men and women, as well as incomplete bladder emptying and the bowel incontinence, as Chris was speaking of. So we'll get right to it. I see every day in my office a plethora of bladder or bowel symptoms, and people's lives are affected by this to keep them from going to the places they want or seeing the people they want to see. They ask themselves, will I ever regain control? Can I go on a date? Can I go see my friends? Am I going to go to this family reunion or not? I basically just want to stay home so I won't get embarrassed or have some sort of an accident, or just somebody has to witness me go to the bathroom every 10 to 15 minutes. And then this is better than it's been in the past. I can say in the 90s when I was practicing, people were more shy to come to the doctor about this problem even then, and it's gotten better. But still, as in this slide, 50% of people don't even go to the doctor for this. They just say, well, this is the way life goes. This is the way I was made. This happens sometimes, or I'm just getting older. And basically, that's not really necessary, because there's lots of options for this. Simple, complex, and most people we fix. So this is kind of our guideline for today. It's understanding the bowel and bladder control, just some basic mechanisms and understanding kind of what we do in the office when we see somebody, to gather a history from you, consider doing some tests, going through some questionnaires, trying some simple things, and then explaining some other options. Two of the options that we'll focus on, mostly the InterStim system, and we'll talk some about the neuro system as well as some others. And at the end, we'll have a question and answer system, question and answer session. So what we're going to talk about today is very common. You probably don't talk about this with your friends and family, but people talk some about their other problems. They'll talk about their diabetes. They'll talk about, the ache in their hip, or they got a knee replacement. They'll talk about these things, but they won't talk about bladder or bowel issues. And it's very common. It's typically kept quiet and private. And 1 in 6 people is very common will have overactive bladder. And overactive bladder, we'll talk about a little bit more in a minute, but it's basically a combination of frequency, urgency, or urgency incontinence. Fecal incontinence, which in my office we call it bowel control issues or bowel incontinence, is not quite as common, but more than you think, 1 in 12. And this definitely is underreported or undermentioned. We can't get people to come to the office to even bring this up because it's an embarrassment. And last and foremost, we have all kind of other medical problems. Like I said, people talk about, like this slide here says vision problems and asthma problems. And, people throw around these kind of complaints and problems all the time, and people don't realize the quality of life measures that are destroyed by just the simplest things of bowel and bladder control. So what's normal and what isn't? Well, that's a matter of perception. Somebody may have gone through their life going to the bathroom every 4 hours. Some people it's twice a day, believe it or not. And some people go once an hour since they were a little kid. But so some of that's a perception. But when you start going to the bathroom, bowel movements or bladder less than 2 hours, your quality of life is certainly going to be compromised. It's hard to keep a job. I've had people show up with disability papers because they go so much, but that's really hard to do to get proved or at least accomplished. But they're that devastated by it, they're trying to find results. A lot of people will resort to just wearing pads and garments, refrain from eating or drinking for a certain lengthy amount of times in order to avoid these accidents. So here's some basic concepts I want to throw out there. I'm going to try to use my mouse. I hope you can see it. So this is just showing you your urinary tract. It starts with your kidneys. Kidneys make urine, they filter the blood and parts that our body doesn't need. It puts it in a solution called urine that comes down these little tubes here and then goes into the bladder, which is a storage center. So anything above this line right here, this is the urethra, the tube you urinate through. When you get above this line, a lot of the stuff you can't control or feel. You can't feel your kidneys. Yeah, the kidney stone, yeah, in their block, you can feel them, but you can't focus on this. You can't do any kind of practice. They're there and they're just going to do their job of filtering all day long. And then they just immediately dump down this tube and into your bladder. But your bladder is more complicated. You have some participation in it, and in some ways you don't. Your neurological system coming from your brain down your spinal cord is controlling a lot of this up here, and you have some participation in the pelvic floor. So this is a complicated neurological system, starting from the central nervous system to peripheral nerves. These are peripheral nerves, the one that goes down to your hand. But anything that's in the brain and running down the spine, that's considered your central nervous system. So today we'll talk about later how we can manipulate the peripheral nerves in a way to take over certain functions of your bowel and your bladder. This again is the picture showing your bowel in here. This is your colon. Your small intestines is not shown here, which is very long and small, and it just wraps all around all this stuff. But see, you can't control any of these things. It's not like you can exercise or have any participation, but when it comes down to here, you get into the rectum. Well, there are nerve complexes that are controlled coming to it and from it and up to your brain, and you have some control as well. And this is where a complex task takes place of storage and emptying. And a compromise of that destroys your quality of life. We take this for granted when we're much younger years. This is a very complicated system that we have ways to manipulate and fix by way of stimulating the peripheral nervous system. Well, I get this question in my office all the time, and I actually don't have a very good answer. People get frustrated. So when somebody comes in and say, why am I urinating every hour? Why is it that I can be watching TV with my friends and I'm completely having to stop the movie and run to the bathroom, 5 or 6 times during that? Okay, so I have an overactive bladder, but why do I have this? Or what really is can you show me a picture of what the problem is? Or can you do a blood test to tell me what can be fixed? Well, it doesn't work that way. I mean, you could have the healthiest body in the world and you can get an overactive bladder, or you can start having stress incontinence, which we'll talk about in a minute. You can cough and sneeze, and all of a sudden you're urinating down your leg. And you say, well, why did I get this? And I just, in a nice way, I have to say, well, that's just bad luck. I hate to say it. I mean, why a woman can have 9 babies and be 90-something years old and have all the control in the world, and you have somebody else that has a baby that's only 6 pounds and only have 1, and then all of a sudden they have all these bladder and bowel issues. So there's not a fine line. You can't blame it on genetics. It's just one of those things. And then we have a lot of things we can do to fix them, but I can't give you X-ray or a blood test or this magical answer that just tells you, oh, okay, this is why I have it. I've always wondered. We're not that good. We're not that good. Fortunately, we have solutions. We just can't tell you the causes as well. So these are 3 different types of urinary control and emptying issues. This is stress incontinence. This is very common. Today, we're not going to talk about the treatments for this. This is those that leak when you cough, sneeze, laugh, swing a tennis racket. Getting on a trampoline is the ultimate test. Just getting out of bed or getting out of a chair, just standing and almost just pouring out like a teapot. As soon as you stand, you just pour right out. That's one of the more severe cases of stress incontinence. And these are more of a problem with the pelvic floor. And these individuals, if you're female, end up getting a urethral sling or some other smaller bulking agent. and I do quite a lot of these, but more so today, we'll talk about urinary retention and overactive bladder. Urinary retention can be, the average bladder is about 450 cc's, which is not quite the size of a 16-ounce bottle, or close. And incomplete bladder empty can be that every time you go, you only get half of it out, or maybe you only get a third of it out. Or some people just can't go at all and they have to rely on straight catheterization. So that's a realm or a range of urinary retention. Overactive bladder is the one we mentioned at the very beginning, being so common, 1 in 6. Well, again, that's a combination of frequency, urgency, or urgency incontinence. Usually they they designate overactive bladder if you had 2 of those 3 symptoms. But some of the treatment options that we talk about, you can just have 1 of those symptoms. And is it overactive bladder? Well, you can say this, but what if you just have severe frequency? You're getting up 10 times a night and you're urinating 20 times a day, but you don't really have urgency. You just got to go and you're able to get there. Well, you don't really call that overactive bladder, but you've got severe urinary frequency, but that would be lumped into category 3. So stress incontinence, again, is like when you cough, sneeze, and laugh. This is an operation I commonly do. It takes 35 minutes in the operating room. We put in a sling. I've been doing those for over 20 years. The mid-urethral sling, they go on the same day. It is remarkably better than what I did in the late 90s, where we, used a bunch of stitches to tack a lot of things up. Literally, that's what we did. And people made jokes of that, but that's what we did. We used to make slings from scratch. But even though there was controversy about a decade ago, if you ever came to my office, I could explain that to you if you wanted to. But modern day urethral sling, outpatient surgery, I do these every week. Been doing them for years, and they work fantastic. Urinary retention. So the device we're going to talk about in a few minutes is FDA approved for urinary retention. There are very few options for urinary retention, and most people have to resort to catheterizing 4 times a day or just leaving a catheter in place. There is no pill. There is no good exercise to reverse this. And in men, this can become severely uncomfortable. And this accounts for a lot of trips to the emergency room, not being able to empty the bladder. So again, the overactive bladder, I've already been through this probably twice. This here says going to the bathroom 8 times a day. Again, that's all perception. You can look at different literature and articles that they would use 10, or they would use just perception of what the patient thought was too many times a day. But basically your life, your social life, just your work life, family life is compromised. But how many times you have to go to the bathroom, or the fact that you're having so much urgency, you're either wetting a pad or you just can't get to the bathroom in time, or always thinking about where the bathroom is. Bowel incontinence or fecal incontinence. So with bowel incontinence and fecal incontinence, kind of the same thing. We have an FDA approval for this in a minute we'll talk about. There are not many options for this. It's unfortunate the surgery that's done down in the sphincter area for years to try to help those with leakage or just gross leakage that they don't even know what's coming. It just doesn't last a long time. You can get some good success up front, but later on down the road, the problem comes back. And it's not like something you can operate on over and over again. And it's probably done less often than it has been in the past. In the future going forward, it's more likely that you'll end up getting some sort of a neurological implant like we're going to talk about, or some aggressive physical therapy. And there are a few medications. So how do we approach this? And then how do we move forward with picking treatment options? Well, with the overactive bladder and the fecal incontinence, we obviously are going to do an extensive questionnaire. There are a lot of key questions I ask that are just second nature to me in order to get down to whether what track you need to go in, what path will work best for you. We might do some tests on you, urodynamics. We might do manometry on your lower bowel. We certainly might make you do a bladder diary. A lot of times your insurance dictates us doing those kind of things to make sure you cleared out all the common or conservative issues that might be causing your problem. We might suggest dietary changes, as it says in the slide. A lot of it is fluids. I mean, some people are drinking way too much caffeine. I've seen people come to my office and they are having bowel control issues, and literally they're drinking 6 cups of coffee a day. And then 6 cups, I'm talking about a measured 6 cups. There are people still drinking 2 pots of coffee a day. I'm talking about 6 cups, which is maybe a half a pot of coffee, And I always say that, the older you get, caffeine is always going to let you know in some way that you can't do that anymore. You'll have to wither down to 2 cups or hardly any at all. People have bowel incontinence, arrhythmias, anxiety. bowel control issues, they get stomach issues. It just catches up to you. And I see it time and time again, their bladder and their bowel is completely messed up because of how much caffeine they're drinking. Of course, that could be energy drinks and tea and whatnot. Just talked to a guy today that drank a gallon of tea a day, and he had all these problems for years, and nobody even thought about telling him that. And just as soon as he stopped that, all his problems were gone, completely gone. So I'm not bagging on tea, but anything with caffeine. In fact, tea doesn't have as much caffeine as, say, a standard cup of coffee or energy drinks, about maybe as much as a can of Coke. We have many medicines we will try you on. We'll go over that just a little bit more in a minute. There's probably 7 or 8 of these on the market. None really for the bowel incontinence. There are some bowel storage medications we can give you, but they're not designed or FDA approved for bowel incontinence. And then we're going to talk about some advanced therapies. So again, the diet and the exercise. When they say exercise, most people do Kegel exercises incorrectly. I'll just quickly give you a tutor. I say, if you sit down on the toilet and you urinate and you stop your stream halfway through it, if you can't do it, then you'll probably never been able to master a Kegel exercise. But if you can do that one action, then when you're not urinating, you're between commercials on television show, or maybe you're sitting in a stoplight, you can do a repetition of 10 of those, doing that same action where you're stopping your stream. That's a Kegel exercise. Most people just squeezing and trying to stimulate and do things on their pelvic floor randomly, it really accomplishes nothing. And down here, this bottom physical therapy here, that is a genius approach to handling a lot of pelvic floor problems. And you can go to a physical therapist now that are trained in pelvic floor. We have 1 or 2 of them in Carrollton, and that is a great outlet for overactive bladder. If you have minor symptoms, not the severe ones, and even minor stress incontinence or just some pelvic floor issues, we would need to guide you on that. You'd have to come see us. You can't just make an appointment. I think they can help you out, but that is a underutilized therapy and treatment out there that people should seek out in certain cases. Going to the medications. Well, oxybutynin was around before I was a doctor. I was a doctor in 1996. And oxybutynin has been around for a long time. It has got all these side effects like dry mouth, constipation, the hypertensions with some of the newer overactive bladder medications. I can name out a bunch. At the end of the 90s, some of y'all may have heard of the medicine Detrol LA. That ruled the roost by Pfizer in 1990 and at the end of the 90s, like 98, 99 and whatnot. And that was the most popular for the longest time until Vesicare and Nablex came out and Toviaz. And now we got Myrbetriq and we've got Gemtesa. And I'm not bad-mouthing any of them. These last two, the Myrbetriq and Gemtesa, have the lowest side effect profile, but they're hard to get your insurance to cover. But hypertension is the one that the Myrbetriq and a few people cause it. I mean, this is not everybody that takes it. But these side effects are all noteworthy. And all the ones prior to Myrbetriq, it's not saying this in the slide, is they all have been shown that over time increases your chance of dementia, quite obviously on studies. And we're talking about the Vesicare, the Toviaz, the Nablex, Detrol LA, oxybutynin, trospium, all those things are on the list. And unfortunately, an insurance company will make us try you on those on occasion. And then, I might try somebody for a while. Then I'll get a letter 6 months later, and the insurance says, hey, you're not supposed to be putting that on this person at this age. You might get long-term effects. And we're like, okay, well, here we go. So we know all these things, but a lot of times we have to go through the routine of trying these medications for formalities to make sure that you have, because sometimes I'll put somebody on a medicine and they just love it. I mean, they're like, you know what? I just needed that pill and I'm good to go. But I think in this next slide, I don't believe it does say that. It doesn't, but here's the bottom. I apologize, everyone. Down at the bottom, it's talking about the fallout rate. So you could have somebody on the medicine for 6 months, and a lot of times they don't even come back, and you'll see them 2 years later, and they have stopped that medicine a long time ago. I just got tired of the side effects, and I figured they all had the side effects, and I just didn't come back. So we get a lot of fallout with the medication. Going to more advanced therapies. Now, when I say advanced, we're talking about a little bit advanced and then really advanced. So when I say advanced, all these aren't really that complicated. So when it's talking about the bladder, Medtronic makes 2 very clever systems. They call the InterStim and the Neuro device. We'll see some pictures in a minute. And of course, there's some injected medication, which is not made by Medtronic. And this is Botox. Don't have a slide on this here. The Botox was FDA approved around 2008, maybe, but I do those all the time. And that does work well for overactive bladder. The only problem with that is that sometimes it works a little too good and you have urinary retention temporarily, but that is a procedure. That's not an operation. We do that across the hall. It can last anywhere from well, average is 8 months, but I see it will last 5 months in some people, and some people might last a year. They get lucky, but you can just keep repeating it. So instead of you taking the oral medications we just talked about, they just call us up, hey, my Botox is wearing off, and they come in and get bladder Botox, and that works pretty well. Some people just love that, and some people it doesn't work. Some people just say, well, you know, I've been here so many times, I'm tired of getting this. Let's get a more definitive treatment, which would be the InterStim. The bowel control, way less options here. There's no pill designed for fecal incontinence. Okay. However, it's pretty interesting. If you just come in and we kind of go over your diet just a little bit, and then we put you on Imodium, which has been deemed to be very safe. And different people need different amounts. If you have bowel urgency, like when you know you got to go and you got to rush to get there, and sometimes you make it, sometimes you don't. If you just change the stool consistency with Imodium, you can get a lot of success with maybe taking it 3 times a week. Some people take it daily. Some people take it just twice a week. We are required to document a trial of that medication unless you have some contraindication to it, where you have bouts of diarrhea, constipation, flipping back and forth, then incontinence. I'm not going to give that person Imodium. There's a few other medications as well. And we may actually refer you out to see the gastroenterologist to make sure you're up to date on your colonoscopies, and maybe to get a mammography or anemometry, they call it, where they actually measure some pressures in your lower rectum just to define exactly where the weakness is. But we won't put you through a trial of multiple different diets, multiple different fluids to try, or multiple different medications, because they just don't, it doesn't exist. Oh, I'm sorry. Here's the Botox slide. Sorry, this is showing the aspiration of Botox. You know, people laugh when we get Botox. The nurses always want to get what's left over and use it on their face. I get this joke. It literally is the same Botox. Literally, people using their neck, you know, they use it on the face. There's a lot of very neat things you can do in the human body because it paralyzes muscle temporarily, not permanently. And it's just a 5-minute procedure where we inject it in 20 little places in your bladder after we put some numbing medicine in there for 20 minutes. And some patients really love it. So this is one of Medtronic's products, excuse me. This has been FDA approved around 2008, before 2010. This is a clever device. You can see my mouse. There's a little floppy, like an acupuncture needle, very floppy. This is your ankle right here. There's a little nerve right here, the posterior tibial nerve. Interesting enough, that nerve goes up to the level of the spine, the same level where some of your bladder nerves and bowel nerves come from. But this has been FDA approved for overactive bladder, frequency and urgency, not for any kind of bowel control issues. You stimulate that nerve on a series of 12 visits. You got to come to the doctor's office 12 times a week apart. You can bring your laptop, your iPad or phone, and you don't even have to focus, because this little computer system hooked to this cable right here goes through a process of training that nerve for 30 minutes. It doesn't hurt. I always tell people there's no risk with this. It's just a function of time and money. You got to come up to the doctor's office, check in, pay your copay, and sit there and get this therapy. And it has on head-to-head studies, specifically Vesicare, and I'm not picking on Vesicare, but that was the one they chose at the time because it was the most popular, has been shown to have a better quality of life and better patient satisfaction. Maybe not necessarily like my frequency got cut in half or urgency was gone. And it's just quality of life improvement was better head to head when compared to medication. And this is fairly harmless. And people who do this, they'll do it 12 weeks and then they might come back for what I call a tune-up, whatever you want to call it, where we just do a little 30-minute therapy on that nerve again to kind of remind it. So this is, some people, that's as far as they want to go with it. They don't care if they got to come to the office 20 times a year. They would prefer to have this. But this doesn't cure the problem. You will always need to come back and get that nerve updated in order to remind the nervous system of controlling your bladder. It's hard to explain all that, but there's definitely a place for this. And we've had this 15 years now. So now we're getting to the InterStim system, which I'm going to spend the most time on. I've been doing this over 20 years. It has been a little long. I didn't start doing it right when it came out, but this again was a guy that went to a Cleveland clinic and trained me how to do it. And I brought it back to a small town in Ohio well before it was ever known about. And it's basically the gold standard for overactive bladder. The only thing you can do for non-obstructive urinary retention, and one of the best things that we know that helps with bowel control issues. FDA approved for all 3 of those complaints. And in this picture here, what it is this is the person's backside and their bottom. Well, you know, I'm going to show you a model here in a little bit more in a minute, but this is your, you know, somebody says they broke their tailbone, that's their coccyx down here, but your sacrum is underneath your spinal cord. It already has these little holes in there that are already there. And this InterStim system is a little small, tiny battery neurostimulator that just sends signals through this cable and down through here. And on the other side of the sacrum are your bladder and bowel nerves. So this technology is a minor surgery, but complicated technology. It is not complicated for the patient. So this operation is an outpatient surgery that we do, and that helps all three of those symptoms that we spoke of. And basically, I'm going to show you the spine and tailbone here, not to scare you really, but if you can imagine a person laying here and their head's there and their feet are there and they're laying on their stomach, so their bottom is here and the skin of their back is here. Well, this implant, which is right here in my hand, this is the one that's in this picture, the bigger one. Of course, it's not that big. Now I've got a big hand. Okay. All right. But this thing would sit off to the side like that. And then it'd have a little cable come around here and go in this little hole right here. And a little cable system would be in there, and that's all internalized, and it's programmed just like a pacemaker or spine stimulator. There's some others, brain stimulators, and they make a lot of different variations of this, but that little cable system just stays in there, and that battery inside this implant that sits in your upper buttock area underneath the skin, hidden, you can't see it. Again, it's pretty small. The battery life on this lasts about 15 years. Anybody who got it prior to this year got the previous versions, which last about 5 years. I've been doing that forever. And so this was an advancement of technology to where now it's MRI compatible, and it lasts 15 years. And the surgery to get that out is just make a little incision in the operating room and pull this one out, and plug a new one in with the cable right there. The cable stays in place. So I don't want to oversimplify, but it is a simple operation, I would consider, and the recovery is fairly quick. And you basically come back to the office, and I do some programming. The rep from the company will do some programming and get you on the setting that you need, and you leave it and forget it. And you're welcome to come back and let me check the device ever so often, but sometimes we don't see people for 6 or 7 years, and now it's going to be longer. Some people will be satisfied. They may not come back for 15 years now that the battery lasts so much longer. We do make a rechargeable version. Excuse me, Medtronic does. It's about the size of a thumb drive. We don't put as many of these in. It is a little incision to put that in there, but you'll need to recharge it every 1 to 2 weeks with a little simple belt that we don't have a picture of here today. A lot of the younger people will pick this one. You may not have to undergo surgery maybe every 15 years or more, but it's a smaller incision area, and people now charge everything in their lives, their phones and watches and everything else, and they just charge this thing up right along with it. They don't think anything of it. So that is definitely an option out there, but we certainly put this in majority of the time, the non-rechargeable version. So we can't just take it to the operating room and put that in, and we know how to document all the conservative therapies, the things we do. We can't just set you up for this. You have to be the right candidate, and I'm a cherry picker. I know exactly who to pick. I can usually figure you out pretty soon to know that this is the kind of thing that you need. And so we actually have to do a test on you. Now, we've been doing the test only for the last 10, 12 years in the office. And what we have to do is do a 1 week test on you, where basically an external version of it, an external version. So if you look in this picture, this person has this little strap around their waist and this little packet or pocket that's got a little external version of the InterStim device there. And it is connected to some little wires that go down in this tailbone, and they're external. There's very small wires that we put in the office. It takes me anywhere from 10 to 20 minutes. I've done some in 5 minutes. Of course, I'm in no rush, but it's a needle procedure. And again, if you're laying on the table on your stomach, you're awake, and we need you awake because we need to ask you some questions. And, we just numb up the top of your bottom right there at the bottom, that upper crease. Like, this is your waistline here, but this is where S3 is, this we're targeting. We just put these, numb up the skin here and the bone here, and then we run these little needles on both sides right down in this little hole, and we put this little tiny wire in there. And that wire basically, if this is your tailbone, that wire just sits in there like that. This was a wire, and it's sitting down here, and your bowel and your bladder nerves are all on the other side of the sacrum. And this is coming out your skin, this little tiny wire, not much bigger than fishing line, and we just tape it to your bottom and hook it to that external box, and you wear it for a week. And I will go on to say, and I think there's a slide. There isn't a slide, but I will tell you, after doing this many, many years, again, I'm a little bit of a cherry picker, if you know what that means. There's no doubt consistently over time, 90% of the people that I set up to go get that test done go on to get the implant. 90%. So we get about 10% of people come back in a week and say, I really couldn't tell. Usually it's obvious. In 3 days, you're like, all right, pull this little tiny wire out of me. I'm ready to go set it up. Seriously. And I don't have to talk into it. I mean, literally they're coming back telling me what they need to get done. And, we have our appropriate documentation of what really is success and what is not. So the long-term satisfaction for these, the fecal incontinence, the overactive bladder, and the urinary retention are exceptional, as you can see in these numbers. I can say that those are true. I mean, I might have a guy or a gal come back 2 years later and say, I'm not so sure I'm really needing this or not. Why don't we just take it out and see? Or some people just somehow the problem just got better. We turned it off and the problem was gone. This is not common. I'm just trying to tell you these few fallouts that are here, but just the majority, all of them, they come back to see me every once in a while for a programming or an update, check the battery, or it's time that the battery's run out and I've got to change it out. And I've got one tomorrow night. I mean, a lady that's had one since around 2007, 2008, has been through 2 generations of them. Now she finally gets the one that lasts 15 years and MRI compatible. And she's been happy with it forever. And I don't see her that often. And, so that's somebody who's urgency incontinence is what she has. And she went on a lot of cruises and she couldn't go on those cruises. Her and her husband travel around the world and she couldn't go on these trips until I got this implant. So it was a pretty remarkable story when you talk to her. So is this right for you? This InterStim implant? Well, again, it's at the end of the spectrum on gold standard. It doesn't mean we're going to have you see you, take you a questionnaire, put you on a medicine for a short period of time and just do it. Interesting enough, in some cases that ends up happening, but in some cases though, we sometimes need to do a test on you, a little thing called a urodynamics. Kind of lets me know what's the bladder's doing. We sometimes need to do a little bit more diet modification, get a little more bladder diary from you, just a little more documentation, and maybe try more than one medication. And you might be somebody, just by questioning you and understanding, you might want a therapy or a procedure prior to wanting this gold standard. Well, that concludes the general concept of many things we want to talk about. I'm certainly open to questions. I don't know if Chris, you want to hop on and help start that?
Absolutely. All right, we got some questions coming in. Dr. Cullison, thank you so much for your time. Everyone else, thank you again for joining us this evening. We will dive into your questions right